So welcome, glad you're here on this dark, rainy Oregon night. We're really privileged to have Dr. Christine Crawford here tonight. Just to give you a sense of the format, she's going to share with us some. We're going to have lots of chance for Q&A and dialogue with you all. And then we will have her books for sale. I think they retail for maybe $29, but we're selling them for $20. We got them at a discount, so if you want to buy them, we can take cash or we're set up on Square as well. And she'll autograph books when we're done. So you probably read some about her bio. You know, she's the Associate Medical Director of NAMI nationally. She's a professor of psychiatry at Boston University. She's been in private practice. She's done lots of things. Her educational background, I had to look it up, definitely an underachiever. BA in biology from Boston College, Master of Public Health from Boston University School of Public Health, MD from University of Connecticut School of Medicine, did a residency at Harvard Medical School, and it's just really a delight. We got a chance to hear her at the NAMI Executive Directors Conference in DC, and I immediately went up there afterward and said, "Would you be willing to come from Boston to Oregon?" And fortunately, she said yes. So, welcome, Dr. Christine. And most importantly, she is a mom of 2 young kids. You may even hear some about the 2 of them in the stories tonight. So, welcome, Dr. Crawford.
Yeah, thanks for having me. Thanks for having me. Oh, yes. Thanks for having me.
And also, I appreciate you guys taking time out of your evening to come here. And for me, whenever I attend these events, it's just so heartwarming and encouraging because, you know, with you being here, you know, I really hope that you share with at least one person, at least one thing that you found to be helpful. Hopefully I can provide some things that are helpful, but really the idea is just to share it with your community. So thank you for welcoming me to your community. And sorry if I'm having difficulties with my words. I'm a diabetic and I'm having some issues with my blood sugar right now. So if you notice that I'm not sounding right, it's because I just need 15 more minutes and I'll be back. So thank you for the Capri Sun. Because I imagine folks were like, why is she like drinking a juice box and all that? What is happening? But it's very good. It's been a very long time since I've had a Capri Sun. And it's fantastic. I might have to go to Walmart and buy a box. But anyway, yeah, so my name is Christine, and what I'll do is I'll just share a little bit about me, because I think having that context hopefully will be helpful as we go into talking about youth mental health, and then also touching upon the book. I just want to make mention that all sales from the book go straight back to NAMI, so it helps to fund some of the programs on the national level. And then some of that money goes to our affiliates as well. So if you buy a book, you're helping to support our cause here, NAMI. So I'd like to talk a little bit about why I got into psychiatry and why mental health is important to me. You know, when I was going to medical school at the time, I really wanted to become an OBGYN. And during that time, I thought to myself, oh, everyone knows what an OBGYN does. More importantly, my mom knows what an OBGYN does. You know, it's a happy profession. You know, you deliver babies and everyone is happy and thrilled. And so I thought that was what I was going to do. I became president of the OB interest group in our medical school. I did research in OB, related topics. And then I did my OB rotation as a third-year resident. I hated it. It was absolutely terrible. And by that time, you know, it was February, so we're more than halfway through the third year of medical school, and I had already done my psych rotation. I told every single person, every single attending that, no, I'm going to go into OB. This is really cute and everything. I'm going to do OB, including psychiatry. And I loved psychiatry, and I knew that I was going to love it, because part of the reason why I decided to go to medical school in the first place was I did research at Massachusetts General Hospital in the depression research group, and I was just working there because I needed to pay my bills while I was going to get my master's in public health in the evening. And then I realized, okay, there's more people who are living with major depressive disorder than there are people who are living with diabetes and high blood pressure combined. And so I thought to myself, okay, well, depression and other mental health issues, that's a huge public health problem, for sure. But again, I decided to fixate on OB. But as I went through, I realized in med school that the patients who were struggling the most with their physical related issues, with chronic medical problems, were those who had undertreated or undiagnosed mental health conditions. And they were getting all of the medical help and care that they needed, but I noticed that there was a significant gap. The gap was that the doctors I was working with, they were good at reading the different labs and the x-rays and the MRIs, but they weren't good at reading people from the sense of understanding, do I really understand you as a person first before I see you as just a diagnosis in terms of what's going on with you in the hospital, what's going on with you in this visit. And I realized that I was drawn to understanding more about who my patients were before really diving into the medical piece. And I noticed that I was the only one who was really, really interested in doing that, besides the folks that I enjoyed working with during my psych rotation. So at the end of third-year medical school, where you're supposed to pick which specialty you're going to go into, I finally built up the courage to tell my mom, and my family's from Jamaica, my mom's side of the family, and I told my mom, okay, well, I finally decided I'm going to go into psychiatry. And she said to me, oh, I thought you went to medical school to become a real doctor. And I was like, And that was what I had feared the most, was that, there's very little understanding about what psychiatry is all about, not only in my family, but also in my community. I noticed that in my community back at home, and just noticing in the Black community, there really was an underappreciation for mental health conditions and treatment, but not just in my community, but everywhere. There was so much stigma. And so decided that, okay, I think I'm going to have a pretty significant impact being a Black psychiatrist and being a Black family medicine doctor, because when we look at all psychiatrists, only 1% of psychiatrists are Black. And so I figured, not that, by me being in an exam room with another person of color, that they were definitely going to connect with me and that will help with their mental health issues. I didn't do it for that, but really just the representation to me really mattered a lot, because I wanted to make sure that more people would enter into the profession so that we can diversify the workforce so that it better represents kind of our population at large. So that was a huge piece. The other thing that I started to think a lot about when I was in residency was understanding why it was that the adults that I was seeing had pretty significant symptoms. And I was always curious as to when things started. When did they start to notice a change in how it was that they were feeling and how it was that they were behaving? And all of the adults that I was meeting with, whether in the emergency room, on the inpatient psych unit, or even in my clinic, all of them had signs and symptoms of some sort of mental health related struggle when they were kids. And it was amazing with every, adult that I was sitting with, they would tell me about a story when they were in middle school or in high school or even elementary school. And it made me wonder, well, if someone stepped in and intervened when this individual was in elementary school, middle school, or high school, perhaps things would have looked a little bit different. And so I started to kind of peel back a little bit, and I thought to myself, okay, especially having that public health perspective, I thought, well, I could have a pretty significant impact being a child psychiatrist, and there's only 10,000 of us in the country, And so I'm definitely a unicorn. But I figured, wow, if I could help children, teenagers, as well as their parents, to address mental health concerns in this young population, then maybe, folks wouldn't need to have inpatient stays because the severity of their symptoms wouldn't be that much because they got the care that they needed at the time that they needed. And then as I was practicing, I realized that folks were waiting many months to be able to see me. I noticed that when they would finally see me, their symptoms were also quite significant because their families were just sitting around and waiting. While at the same time, they didn't realize that there were so many things that they could do during that time in which they're waiting to see a mental health professional, but they just didn't know what to do. They didn't know about NAMI. They didn't know about some of the mental health resources that are available in schools. They didn't know about the importance of tapping into their community and talking to other parents about the challenges that they had with their own kid and their mental health struggles so that they can get the support from other folks. A lot of parents weren't doing that. And I also realized that there are so many skills that we could provide our kids as well as our parents just to help with people being able to avoid a situation in which a kid is struggling with their mental health concerns, because I really do think that if we are intentional about providing skills and tools to our kids, then they are better equipped to navigate kind of the stressors of the world, but also how to navigate just big emotions and small emotions so that they can be able to be on the trajectory that they want. So part of the reason why I wrote this book is that Ken Duckworth, who is our chief medical officer, who is he's basically the person who changed my life and introduced me to NAMI when I was a resident. He wrote the first book, You Are Not Alone, and he interviewed over 160 people across the country, those with lived experience, those who were family members of individuals who were living with mental health challenges. And most of the people that he would encounter on the book tour or in other spaces would always ask them, so where's the book about, like, kids? Where's the book that's supposed to help parents to take care of their young kids? Where is that book? So then he called me up one day, and at the time my kids were 1 and 2. They were 1 and 2. And he was like, Christine, people want a book that focuses on youth mental health. I think that you should write it. And I laughed. I was like, I think you should find someone else. But he's a pretty persistent guy. And so for many, many, many months, I would say probably almost a year, he kept reaching out. He's like, you really ought to write this book because people need it, people want it. And so I did. And as part of the process, what I did was I wanted to interview not only kids, I wanted to interview teenagers, young adults, parents, but also teachers, coaches, faith-based leaders, just everyone and anyone who touches the life of a youth. I wanted to interview them to understand what it was that they think about when it comes to youth mental health. What are some of the challenges that they face? And what are some of the things that, especially the young adults, what are some of the things that they wish that the adults in their lives, when they were struggling, what it was that they wish that those adults did, or how they wanted support, what it was they were looking for at that time. And I wanted folks reading this book to hear those things, to hear those stories. I also wanted people to appreciate that when we talk about mental health struggles, they don't just start when you're in high school or in middle school. They could start when you're as young as 4 and 5 years old. And so I interviewed one woman from Alaska who actually attempted suicide at the age of 5. Because around that time when I was working on the book, there was a statistic that just came out about suicide rates of children between the ages of 5 to 12. Now, it's hard to even fathom the idea of a 5-year-old feeling so profoundly depressed and hopeless that they think that ending their life is the only solution. And that is something that happens each and every day. And so part of the reason why I wanted to interview young people was because I wanted them to appreciate, even though they're young, even though they're in elementary school, they still experience the full range of human emotions. Even though their world is small, those feelings are really big, right? And they can be so big that they can really struggle. And so I wanted to make sure that adults and parents also have the tools to be able to support our youngest kids. So the book is set up in a way that kind of is similar to the way in which the book, not necessarily the way the book is set up, but it was motivated by the book What to Expect While Expecting. Because even though I went to medical school, I thought I was going to be an OBGYN, I delivered babies and everything. When I was pregnant, I didn't know what to do. I was like, what's going on here? What am I supposed to know? What kind of fruit is the baby right now in terms of its size and all that stuff? And while reading that book, I just felt just so much comfort, because at least there was some sort of roadmap for what to expect. I could prepare myself, and it really helped to mitigate my anxiety. And I wanted some kind of guide for parents, for adults, because so many parents, they don't know where to start when it comes to having a kid who's struggling. I hear so often that, folks will go onto Google and Google best therapists in the area, right? It seems like, they're just starting from scratch and reinventing the wheel, but it doesn't have to be like that. And so I wanted folks to be able to read this book, and if they were to encounter a challenge or a problem or a concern in their kid, at least they would know where to start. If they have a friend who is struggling with their kid, as a friend, they can share some tools, some strategies, some resources with their friends. And so that really was the motivation, rather than just having kids just wait and wait and wait to see a mental health professional. I didn't want kids to continue to languish in emergency rooms. I didn't want to continue to hear about horror stories from parents. And so I really hope that if you guys do purchase a book, to really just think about it as a tool, as a resource for families. You don't have to read it cover to cover. It's written in the way in which, you could go through some of the different chapters if they're of interest, and just read that one chapter. So the way that the book is set up is broken into 3 different sections. So part 1 is really about kind of understanding your kid. That's first and foremost. And understanding how your kid's brain works. Understanding how to even talk to your kid about mental health conditions or mental health challenges. But also how to know if certain behaviors are developmentally appropriate or are they not. And if you do identify a concern, who do you talk to? There's licensed mental health counselors, there are social workers, there are psychologists and psychiatrists. It can get really confusing for people. So I talk about all the different players that you could tap into when it comes to assembling a team around your kid to support their mental health needs. The next part of the book, part 2, goes through all the different mental health conditions: depression, trauma-related conditions, substance use disorders, psychosis. And I talk about how these different conditions present differently in someone who is 6 or 7 years old compared to someone who's 17. And so just having that awareness of what some of the signs or symptoms are and how they manifest themselves across, different age ranges is something that I go into a lot of detail about in the second part of the book. as well as I have stories from the people that I interviewed scattered throughout the book, because the idea behind the book is that even though I spent a lot of money and a lot of time in school, I'm not the only expert when it comes to mental health related issues. It's people with lived experiences, people who are on this journey. They're also the experts. So that's why they also contributed to the book. Everyone who's in this book is an expert. And then the third part really is focusing on the voices of those folks that I interviewed. So different stories, pearls of wisdom, and what have you. So that's a little bit about the book, and that's a little bit about me. And one of the things that I notice whenever I do some of these events is that one question from the group really just tends to blossom into a beautiful discussion that is able to get everyone engaged in terms of reflecting on some of the challenges that they might have faced themselves, being a parent, or things that they've heard about. So I would just love to open it up to any questions or thoughts or reflections as I drink a little bit more of my Capri Sun.
How old are your kids now?
And if you could repeat back the question for benefit of the video.
Thank you. My kids, the question is how old are my kids now? So they're 4 and 6. And I'm a single mom, and I got divorced recently, so about a year ago. And while I was writing this book, I was really thinking about my kids. Even though I'm a child psychiatrist, I know that if my kids were to face any sort of challenge, and one of my kids has autism, as a parent, you want to do everything and anything in the world to help your kids out. And to not know how to help your kids out is terrifying, right? For a lot of families. And when when my kid was diagnosed with autism, again, I have all of this knowledge, but it was still scary, because what was most scary to me about the diagnosis was the amount of uncertainty about her future. And I hear that a lot when it comes to other parents who have kids who have a mental health condition. You don't know what their future is going to look like. You have your own hopes and dreams, your own idea of what you want your kids to do or how it is you want them to look in the future. But some families, when they receive that diagnosis for their kid, all of that feels like it's gone out the window, when that doesn't necessarily have to be the case. So when I talk to parents, I really, have a lot of empathy for parents, because I know even when parents are upset with me and they're, they have a lot of choice words to say to me, I understand, because it is hard to hear other people talk to you about your kid. At the end of the day, you are the expert for your kid, and to be sat in front of someone else telling you about your kid is the most humbling experience in the world. And so this book too, and just the work that I do, I just want parents to feel empowered to strongly advocate for their kids, because at least they have the language that they can use to communicate with all these different folks, school folks, mental health professionals. They have all the language that we use all the time, so that they can better and more effectively communicate with those people, so that they can understand how it is they're supporting their child. They understand, okay, what does progress actually look like in therapy? What are you guys doing? What does progress look like when it comes to medications? Do we need to stop and reassess? I wanted to make sure that after reading this book, parents felt comfortable and empowered to ask all those questions and to question the professional. So the short answer is 4 and 6.
I got a question. So one of the things that we find a lot is that parents often don't know how to tell the difference between a behavioral issue and something that might be a mental health issue. are there any best practices that you might share for telling the difference?
Yes, so the question is around how do you differentiate typical behavior that's age appropriate versus a concern, an actual mental health concern, or something that requires or warrants further investigation. And this comes up all of the time. And I oftentimes correct parents when they come in to my office and they're like, what's wrong with my child? There's something wrong with them. What is the problem? And I try to help them reframe the question to help me better understand my child. Because it's not a problem that needs to be fixed. It's something that we want to better understand in terms of how it is that this kid is thinking and experiencing the world and how it's influencing the way in which they're feeling and the way in which they're behaving. So we want to understand your kid. Now, I focus a lot on functioning. That is really kind of core to what it is that I do as a psychiatrist. So if you have a kid who is struggling to take care of themselves physically, so their sleep patterns are off, they're not eating the way that they would usually eat, they're not getting out of bed, they seem to be exhausted, they're not attending to their personal hygiene, and you notice that that is a shift from their typical pattern of behavior, that's one thing. But then also if you're noticing changes in the way in which they're functioning socially. Are they more withdrawn? Are they spending more time in their room? Are they no longer hanging out with their friends? Are they skipping cheerleading practice? Are you noticing changes in that domain? We tend to focus a lot on how kids are doing academically, but the reality is that it's actually a helpful marker because they spend a lot of time in school and being in school is their job. And so if we see that their grades are dropping and previously they were pretty stable, then we're concerned. In the book, I talk about this concept that I made up when I was sitting in a coffee shop. It's called the distress radius. And what that is all about is if you are a parent and you're noticing some changes in your kid within the home, or you're noticing some changes in the dynamics between you and your child, you should be curious if this is a pattern that also is observable outside of the home. Is this something that we're also noticing in school? Are we noticing the irritability? Are we also noticing the withdrawal? Are we seeing those things in other aspects of that person's life, of that kid's life? So when we think about at its core is what's happening in the home, and then as we go further and further out, if we're seeing that not only in school we're seeing challenges socially, but are we also seeing challenges in terms of their community, how it is that, they're interacting with their faith-based community, how they're interacting with extended family members? Are we seeing these sort of behaviors in different domains of that kid's life? And if the answer is yes, then there is a concern. If the answer is yes, and this is a change from their baseline, then it's a concern. So really it just comes back to functioning. Are you seeing a pattern of impaired functioning in multiple aspects of that kid's life? If so, I tell everyone, first and foremost, you got to call the pediatrician. Now, people forget that mental health concerns are primary care concerns. And you can call up your pediatrician for an urgent visit to bring up these concerns. And a lot of parents don't realize that. So you can call up a pediatrician and say, I have these concerns, I'd like an appointment. And you can get an appointment within a week, couple of weeks, or a month. You can't do that with a child psychiatrist, right? So these concerns are primary care concerns, and so that's a time when I would bring it up. The other thing, too, is that a lot of parents think that you have to have some of these changes in the kid's behavior, changes in the way in which this kid is functioning for a long period of time. And I tell parents it's really just a couple of weeks. That's it. I got 2 weeks? I'm like, absolutely just a couple of weeks. But the number of kids that I see who have experienced symptoms for months, not years. It's just far too many. So it's important for people to know. It's just a matter of weeks. If you're noticing these changes, just 2 weeks, you can bring that concern to your primary care provider.
So, what I've read previously, a lot of times autism may be, or schizophrenia may be misdiagnosed with autism. So when you have younger kids, I'm not, usually like schizophrenia will come around in later teen years or earlier on. I don't know if there's signs of that when they're actually younger.
Yeah.
Or not, because our son, thought he had ADD.
That's how it's diagnosed.
But, then eventually he realized schizophrenia. So I'm just not certain about if there's preliminary signs before they actually become,
If there's new evidence base.
Yeah, no, it's a great question. So the question is, how do you differentiate between autism and schizophrenia, and if autism or even ADHD, or if there are other signs that indicate that perhaps this kid might be on their way to developing schizophrenia, is the question. So one of the things that I talk about in the book, I talk about how to think about diagnoses. And when it comes to kids, because we know kids change over time as they should, they could be diagnosed with something at the age of 7, maybe have a couple of other diagnoses that they're given along the way, and then at age 16, they have this list of different diagnoses that to me doesn't really make sense as a psychiatrist, because one doesn't make sense with the other one. It's like schizoaffective disorder, schizophrenia, bipolar disorder, psychosis. It's like everything. And the concern is that kids are just, racking up all these diagnoses, right? But what I tell parents is that the diagnosis that you received for your child at that time was what the symptoms looked like at that time. And that diagnosis is really just a way to describe the experiences that kid was having in that moment of time. And so diagnoses, they change over time because kids change over time. So say if a kid was diagnosed with ADHD, and then as time goes on, we're starting to notice that their problems being able to focus, being able to concentrate is secondary to anxiety, then anxiety might be the diagnosis that makes sense in that period of time. The other thing, too, is as psychiatrists, we oftentimes focus on treating the symptoms that are impacting the kid's ability to function and the symptoms that are most distressing to the kid. And so sometimes the diagnosis doesn't even matter because whatever supports, whatever medications, we're really just focusing on, improving their overall functioning. So yes, sometimes people get different diagnoses, but things change over time. Now, when it comes to schizophrenia, we do know that there's an association between what we call neurodevelopmental disorders and those going on to develop primary psychotic disorders like schizophrenia. That's basically a lot of words to say that if we have kids and it looks like their brains are different from other kids, that difference creates a vulnerability that may predispose them to developing a whole host of different conditions, including schizophrenia. So it doesn't always mean that if one has a neurodevelopmental disorder, they're going to go on to develop a psychotic disorder, but there is a higher likelihood that we see. Autism is another neurodevelopmental disorder. It's in the same category as ADHD, and people don't realize it. In the DSM-5, I know people have feelings about the DSM, but again, it's just a way to describe a constellation of symptoms. But ADHD is in the same kind of chapter as autism. Now, with autism, it can be really, really tricky because there are several things that are critical to diagnosing autism. Are we noticing some challenges when it comes to communication, when it comes to social communication. Are we noticing that they have restrictive interests or repetitive behaviors? And also we do see some sensory related issues as well. When it comes to the early symptoms of psychosis or schizophrenia, we do see what we call negative symptoms of schizophrenia or psychosis. So what that means, these are the symptoms that we classically see before people go on to develop things like auditory hallucinations, so hearing things other people can't hear, or visual hallucinations, seeing things other people can't see. Those preceding symptoms include social withdrawal. It includes a lack of motivation. It includes kind of emotional flatness, like they don't really have very reactive, or they're not very expressive. And also we see a decline in their functioning in several different domains, including just their ability to, do the things that they would usually do. So sometimes some of those symptoms of autism can look like those negative symptoms. But the thing about autism is that, especially nowadays, it's actually really good, but most kids are able to receive a diagnosis prior to the age of 5. There's also some indications early that kids aren't able to meet their developmental milestones, so talking on time, walking on time, toiling. We see that a lot in autism. But also, there is no change from their baseline when someone has a diagnosis of autism. With schizophrenia, there's a change from their baseline. And so that's the biggest thing, is that things are different. You can have autism and schizophrenia, but it's really what I'm focusing on is there a change in overall functioning that's different from their baseline? You're right. Most kids or young people tend to experience most of the symptoms that we know that we call positive symptoms, the hallucinations and what have you, when they're late adolescents, typically between 18 to 25 or later on in their 20s as well. That is the usual course. Early onset schizophrenia is being diagnosed under the age of 18, and early or child onset schizophrenia is prior to the age of 13. Now, those types of diagnoses, it's like less than 0.05%. It's like incredibly rare. So when I hear about a 12-year-old who's hearing voices, seeing things, has a lot of paranoid thoughts, I'm thinking about something else. My first thought isn't schizophrenia. It's oftentimes trauma, and that's kind of their trauma response. So I'm always curious about other things as well. Again, I have these long-winded answers, so I'm so sorry. Yeah.
Good.
Yeah.
Our son, it's interesting what I'm hearing you saying, because the symptoms started, I think it was around 16, 17 or so. He started hearing voices. He started hearing, he would come downstairs. Mom, did you call me? Dad, did you call me? In the beginning, he would laugh it off, Papa, no one called you. It started to happen more and more, and just different things. And so I sat down with him and I said, I would like to take you to counseling. The counselor, we also went to church with him. He was kind of like resistant, but at that time he was underage, so he had to do what he said, basically. So he did. And I said, look, if it makes you feel better, I will not be in the room. I will be sitting outside the room. If it's going to help you open up, I don't have to be there. And so we did. We did some sessions, or he did. And she couldn't tell me exactly after the fact that when we really started dealing with it more and more. And there was a I think she's I forgot what they're called, oh my gosh. But we have a friend that also is a psychologist and psychiatrist that used to come in and and get people diagnosed before she could say, okay, let me sign off and, you know, they would send that person somewhere. She practiced in Washington. And so when we started noticing all that, and I kind of wanted to know what exactly was she seeing that was a pattern. Oh, because at one point she said, let's try medication. That's when he flat out at that time said, oh. So he's refused medication because he says, there's nothing wrong with me. There's absolutely nothing wrong with me. You know, we approach him we've approached him every way, gently, not so gently, you know, because you get frustrated. So now it's just full blown to this day. He really believes there's nothing wrong with you. You know, the problem is all you. But it's obviously paranoid schizophrenia and some other stuff is what we figured out. What was that word, Gary? Where they don't think there's anything.
Oh, you're talking about anosognosia.
Yeah. So, and I mean, we have a doozy, you know, just a combo of things. And
Our son doesn't, he's ill, but he's realized, well, it's been about an 8-year journey now.
And he's coming around and he talks about it.
Hospitalized twice.
yeah,
And people have told him often enough.
and he.
Yeah, and so he takes medication because he knows it helps.
That for us would be like, oh, Jesus.
Oh, I know, yeah.
But it's just not happening right now. Not saying that in the future. I mean, the last thing that goes out the door is hope. So we're always hoping that he'll come to that place. But you know, the symptoms we started seeing and progressing in high school. Very highly intelligent kid. Didn't care about his grades. You know, kind of like barely passed. You know, each grade and all that. And we knew he could way better than that. So it's interesting how you said that a lot of the stuff was seen after, but we started seeing it just before, and it kind of gradually just started to really show more and more to love, you know. So
And thank you for sharing that too, because, you know, to have a kid that you love and care about and you just want to help them and you see that they're struggling, that is so painful. You know how you could help them. It's right there, but they don't want to because everything is fine. They don't think that they have a problem. And so that's a really challenging thing to deal with as a parent, knowing that your kid is struggling, but they're refusing treatment because they think everything is okay. And you also brought up the point around some of the things that you started to notice that were different, and how they kind of presented themselves over time, especially when he was in high school, and then how it then evolved into something else. So I'll talk about that point first. Now, what's often confusing is that what I refer to as negative symptoms of psychosis, so that's the lack of motivation, the social withdrawal, you're noticing that maybe their personal hygiene is different, their grades are dropping. Oftentimes, it's hard to recognize that phase for a lot of parents, especially of teenagers. And they oftentimes chalk it up to something else. Oh, they're just being a typical teenage boy. Of course they're going to want to stay in their room. Of course they smell and don't want to take a shower.
well, thankfully that's never been a problem with me.
Yeah.
Very clean kid, thank God.
Yeah, and so we call those also prodromal symptoms. And they're hard to spot. And that's why I like to talk a lot about them, because when families are able to pick up on some of these subtle changes, kind of investigating a little bit further could be helpful, but because there are actually things that we can do to kind of reduce the intensity of the psychotic experiences that they have later on. We're just learning a little bit more about kind of that phase. And then we see folks go on to, you know, hearing voices, like you had mentioned, your son experience and what have you. Now, when it comes to teenagers, what's interesting is that kind of those symptoms, they look a little bit different in teenagers. So I often hear from teenagers that they experience these perceptual disturbances. It feels like things are distorted. So when they look in the mirror, like their image looks somewhat distorted, light has color in it, and these are all experiences that are hard for people to articulate, especially for kids or teenagers, so they just keep it inside for a long time. And so I think when it comes to psychosis, there's a lot that the general population doesn't know about it because it isn't something that we speak about as often, and we should. People know about anxiety and depression, but there's, not everyone commonly knows about psychosis. Now, the point about, well, what do you do if your kid is refusing treatment? This is the hardest thing. As psychiatrists, this is a terrible term, but this is something that we often think about. It's unfortunate that for a lot of people who think that everything is okay, they don't think that they have a problem, we do what we wait for the person to declare themselves. And what that is code for is we wait for a crisis. It's terrible. It's terrible. Because then they go to the hospital.
Yeah.
Once someone's in the emergency room, we finally can kick into high gear and do something.
Oh, he's been there, and we've tried, and you're just fighting against the system too.
Oh, yeah.
That's,
Yeah.
so, yeah.
And I think it stinks because it's like, why are we relying on someone presenting to the emergency room to, be able to jump in? But oftentimes we do have to wait until that moment. It's terrible. And when you're a parent and your kid is in the emergency room having a set of experiences that are quite distressing to your kid, to you, and you see them just sitting there and sitting there for one day, and then that turns into 2 days and 3 days to 4 days. And it's because we don't have enough child psychiatry beds in the country, and they just wait.
Well, he's a young adult now.
Yeah.
So, he's no longer a teen.
Yeah.
So it's been a process. He's 25 now.
Mm-hmm.
So that's how long we've been kind of dealing with all of this.
Do you have guardianship?
That is one of the things that we wanted to work on, but that was super expensive. When I talked to an attorney, that's the route I was told to go. It's like, oh my gosh, are we sure?
There's no guarantee you'll get it.
Yeah, exactly. You can deny it.
Yeah.
We went with that guardianship, and the attorney quoted us, $2,500 to come out of $1,500.
Oh, I was working.
Well, because you didn't fight it.
Yeah. So for the people who are on videos, the question or the discussion is around guardianship. And I know I'm spending a lot of time talking about teenagers and what have you because, no, this is all relevant. It all ties in. Because a lot of, I know that your son is 25, but there's a lot of parents, it's helpful for them to know what they can do beforehand because, again, it always seems as though it waits until things kind of hit the fan. When it comes to guardianship, I talk to parents about that way before the kid turns 18. Because once the kid turns 18, that's when the whole game changes. That's when your kid will say, yeah, I'm not going to sign a release of information. I don't want you talking to my parents. And once you're in that, that's hard to get out of. Now, one thing that people don't know or fully appreciate is that as a parent, say if your 19-year-old refuses to have you involved in their care, you can still call your kid's provider and you can share information, you can share concerns that you have with them. They can't tell you anything, but that information is beyond helpful to the provider.
Mm-hmm.
So yeah, even if they're like, no, you still call, you still show up, you do everything, because that information is vital. So with guardianship, if I notice that there's a kid who's been kind of in and out of the hospital a couple of times, or they have what are called Department of Mental Health kind of services, which is something we do in Massachusetts for more high-risk folks who have been in and out of the hospital a lot. I'll say, okay, your kid's been hospitalized 3 times now, and I'm just concerned that when they turn 18, things might change in the way in which they're engaging with care. I do think that right now we should think about guardianship. Or say if the kid is 17 and they're on an inpatient unit, I'll strongly recommend that they begin the process while the kid's in the hospital, because you can have social workers who begin the paperwork and help guide you, and things kind of move a little bit quicker. So folks also don't know about that piece. So as soon as someone's in the hospital, I'm like, all right, so what we're going to do is A, B, and C. We're going to get you DMH services. We're going to apply for guardianship, get that paperwork going. And then what's challenging is that a lot of parents don't have the conversation with their teen about why it is they're pursuing guardianship and what it means, right? And so for a young person, they're like, wait a minute, like, I'm an adult, like, I should have some autonomy and blah, blah, blah. But if it's presented kind of in a way in which it's like, yeah, no, you have full autonomy and what have you. However, this is something that is helpful when things are a little bit difficult and you're really struggling with your health. Because guardianship is not just for mental health related issues, it's everything, in terms of health. So if you're really struggling, at least this allows me to talk to providers and help to make some decisions when you are not doing well. When it's presented as such, sometimes it's a little bit easier for the teen to tolerate it, rather than it feeling like it's always going to be a thing in terms of they're going to control, your parents are going to control every aspect of your life. It's just when things are a little bit challenging. I also talk to families about when kids are doing well or when they're out of the hospital, to have a discussion regarding what are some of the things that kind of would, how do I say this? I have a conversation about, okay, what are the things that we are all going to be looking out for to indicate that things aren't going well, or to indicate that you're struggling? When we notice X, Y, and Z, are you in agreement with this? Are there other things that we should look out for that you could take notice of? That means that things are changing, that things might be going in a different direction. Okay, let's write that down. Now, if we notice these changes, if we notice that this is happening, are we all in agreement that this is the plan? That's another thing that's also really helpful. Now, in the moment when, there is an episode, and you can show the paper and do all of this, oh, what are you talking about? At least you feel a little bit more confident knowing, okay, right now they're not in agreement. However, we discussed this before, so it's a little bit easier to kind of lean in with the plan, whether it's to go to the emergency room or to call the psychiatrist or to call mobile crisis. At least you feel a little bit more confident doing so because it's a plan that was discussed ahead of time. But guardianship is very complicated and it's very confusing. It's so confusing. And some of the families that I worked with in Boston when I was at Boston Medical Center, which is a large safety net hospital, so 90% of the patients were on Medicaid, if not more, 95%. And the number of times that I would have to refill out some of the forms for guardianship, I mean, there was one parent, I think I probably filled it out like 5 or 6 or 7 times, and it was because she couldn't figure out like the next steps. Like she would go to the courthouse but didn't show up on the right day or didn't have the right form. She didn't come, and it was just so confusing. And so I spent 2 appointments that were scheduled for her son just to do the paperwork with her and to make the phone calls and everything. It was just so confusing and overwhelming. But the short answer is that I think kind of having the conversation about guardianship or thinking about it before the kid turns 18 is super helpful, but it can be hard to consider that as an option at the time.
We did get it for him after he was 18, but the second time when he was admitted, we had guardianship, and so that made it a lot easier for us to control that situation, especially when we got into unity and they wanted to
And the other thing too, when someone's in the hospital for psychotic symptoms, we do have the option for a long-acting injectable. And I know I'm spending a lot of time talking about meds, but just because we're kind of on this topic in terms of talking about inpatient stays and what have you.
We can't do schizophrenia without it.
Well,
I mean, it needs meds.
Yeah. So there's long-acting injectables. These are medications that help with the psychotic symptoms that you could take once a month. Some of them you could take every other month. Some you could take every 3 months. And a lot of people have concerns about long-acting injectables because they're like, wait a minute, so you put all of this medicine in my body and it just floats around for 30 days and like, isn't that going to make me more sick or experience more side effects because it's like so much medicine at once? It's actually the opposite. When you have all that medicine administered, it literally is designed in such a way that it slowly releases the medicine over the course of the month. That's different than when you're taking a pill every day. You're more likely to experience side effects because of the way in which it's being metabolized and broken down in the body is a lot faster. And so people tend to experience fewer side effects when they get a long-acting. The other thing, too, is that long-acting medications is not unique to psychiatry at all. Has anyone heard of Ozempic? You know what I mean? Like, there's a whole bunch of meds already that we give that are considered long-acting, but we don't think about it in a scary way in the same way that we do with some of our antipsychotics. So I always like to make mention of that. Ozempic is just one example, but there's other ones that aren't just for weight loss that are also long-acting. Like depot shots for birth control, you know what I'm saying? Yeah.
I just want to say thank you for writing this book, and I'm really anxious to read it, like cover to cover tonight. Because I feel like when my son is 22 right now, but when he was starting to have symptoms when he was younger, we didn't really know what it was. It really wasn't too severe. We were thinking it was just kind of behavioral. He's being a teenager or whatever. But what happened is he started using marijuana to suppress things. And that got worse. And I was wondering if you could touch on that a little bit. And I was really happy to hear, I mean, I don't think there's anything happy to be talking about right now, but it was interesting to hear you say that some of the symptoms earlier on that are behavioral, like we're thinking he's some level of schizophrenia. It's not diagnosed quite yet, but you were mentioning that it could have been because of trauma. And what we have found in the last year is that he did have some trauma that we completely did not know about at age 8. That came out, and he just had a 30-day residency in Utah, and they were able to pull that out of him, and completely did not know about that at all. So, like, how his treatment plan will go and change and evolve will be different because of that. But the cannabis-induced psychosis is so frightening. That is what his thing is. And so for about a year he didn't use anything, and then he used it, like he took one hit off of a joint and he was right back into it, and it lasted for a full month before we could deal with the emergency room and the whole 9 yards and get him into a residential program. If you could speak to the cannabis part of that.
Absolutely, yes. And also to your point about trauma and just finding out about that now. What's so challenging when it comes to, mental health related concerns is that there's so many different factors and so many things can happen all at the same time. And sometimes we kick ourselves for not being able to know X, Y, and Z. But at the time, you did the best that you were able to. You did the best that you could with the information that you had at the time. So I do think it's helpful that now you know kind of what else is contributing to the presentation. But I'm happy that that was able to come out. So the question was around cannabis use and psychotic symptoms. So I always like to start off by saying that yeah, I know, back in the day, maybe you smoked some weed, like in the 70s or whatever. But weed looks different now than it did back in the day. So the potency is through the roof, right? So flower looks different now than it did back in the day, for sure. And that's what the problem is. That's why we're seeing psychotic symptoms on the rise in young people, because of what it is that they're smoking and how it is that they're also consuming cannabis. There are kids who aren't just smoking joints, they're vaping, and the vape is a huge concern because they do it all throughout the day in the bathroom. They do it all throughout the day while they're walking to school, when they're walking back. And so there's hit after hit after hit, when back in the day you were only able to get a hit when you would go to Johnny's house on the weekends, you know? But now folks are doing it every day.
All day.
All day. And then it's also mixed with a whole bunch of random stuff. That's also a mess. When I say random stuff, I'm also talking about synthetic forms of cannabis. So in Boston, we have a problem with something called K2. And, oh my gosh, so it's synthetic, it's not naturally grown, but it causes pretty significant psychotic symptoms. So there's that. And then also kids are doing what's called dabbing. And that's using like a wax, and that's the worst because the potency is, it's through the roof. So the number of kids I would see on an inpatient psych unit when I was a resident on a psychotic unit, most of them were dabbing.
Yep.
So it's like this,
That's what they're doing in Clackamas County, FYI.
It's a resin. It's a concentrated resin that you smoke like you would smoke like a pipe. And it's very, if you Google it, I mean, you will see, it's basically like getting hit with a truck. It's been very, very intense.
very intense. And one difficult conversation I had with a parent, and it was a similar situation. It was a 16-year-old. They were hanging out with friends, and they smoked marijuana for the first time, developed some psychotic symptoms, and then remained psychotic ever since. And it was just one hit. But then later on they continued, but really it was that one hit that just changed everything. This family came in, and they're like, we don't know what to do. He's buying it at school. I see that there are these vape pens. We don't know what to do. And he wasn't going to school at the time. And I remember when I said this to the family, I felt really guilty about it, and I was kicking myself. I'm like, what kind of doctor am I? That was a silly thing to say, but I thought it was a helpful thing to say in a moment. I said, as part of a way to motivate him to go to school and to mitigate any potential risks that he could be exposed to from getting cannabis randomly from kids, I explored with the family. I was like, I wonder if we could say every Friday, if he goes to school 5 days a week, that you could go to the dispensary and buy him what he wants, a pre-rolled joint or whatever. Now, in my mind, I'm thinking, okay, that's a harm reduction approach, and also that's using an incentive to motivate the kid to actually go to school. But in my mind, I'm like, it's actually safer because they'll know, because there's so many different products. You could see what the THC content is. You just pick the lowest thing, and here you go, Bobby, you know. But I remember just having a lot of guilt about that. The other thing that we're noticing is that kids are smoking a lot younger. Oh my goodness. So I'll never forget, I was talking to one family and the kids started smoking at 9. So folks are using a lot younger because it's just easier to get access to. It's like in a lot of people's homes already, and they can just start using it. And it's been kind of normalized in terms of frequent use. And parents may have different attitudes about it. But the younger that you use cannabis, the more likely that you'll go on to develop a psychotic disorder. That's what we know from the literature. And so I tell teens, I'm like, I couldn't care less if you're like a 20-year-old, 21-year-old, and you're smoking all the time. But at 14, I care a lot. Because, you know, the brain is really developing, and it's a critical time of development. So I really tell kids, stay away if you can't. Now, those who go on to develop psychotic symptoms, it's hard when you tell them stop using because all their friends are using. And they're like, well, it's not a big deal. Like, my friend smokes all the time and they're fine. It's not a big deal. And I'll say, well, it's a big deal because you and I are having a conversation right now and Billy isn't talking to a psychiatrist. So there's a difference here, right? You were in the hospital after smoking. Billy is at home, right? Think about it like this, as an allergy. It's like if I had a chocolate allergy and everyone likes chocolate cake and everyone's eating chocolate, it would be silly for me to have a slice of that chocolate cake just because everyone else is. It's the same way to think about cannabis use. And for some kids, it's helpful for them to think about it. But long-winded answer to your question, but I'm seeing folks develop persistent psychotic symptoms after just a few hits of marijuana because the THC content is so much higher and kids are using younger and younger. I'm also seeing it with stimulants. So overuse of stimulants like Ritalin or Adderall, that can also contribute to psychotic symptoms. And some kids, they like to gain access to stimulants for performance enhancement reasons, but for some kids, they can, if they're taking too many pills, then that could also contribute to psychotic symptoms too. There's also things that we recommend for folks to take to reduce cravings around cannabis. So something called N-acetylcysteine, also known as NAC, and this is an over-the-counter supplement. Studies have found that it helps to reduce cravings for marijuana. And a lot of people are like, wait a minute, crave marijuana? That's a thing, but it is a thing. There's also symptoms that people experience from withdrawing from cannabis, which is another thing that people didn't realize happens. But it's happening more and more now because the THC content is through the roof. So people are experiencing withdrawal symptoms. People are experiencing pretty intense cravings. So NAC is really helpful.
Acetylcholine.
Mm-hmm. Or cysteine. Oh, cysteine, yeah.
Last call for questions.
Hi.
Hi. I am in need of some, I'm going to ask you both questions, actually. I was just going to ask the hopeful one, but I want to hear both of them.
Yeah.
What is the thing that worries you most right now about our kids' mental health?
Mm-hmm.
And then where do you see the most signs of hope? Or what are you most hopeful about?
So the question is, what am I most hopeful about? And the other question was, what concerns me the most about kids' mental health? I'm most hopeful about the fact that kids know how to advocate for themselves more now than ever before. They're more comfortable talking about their mental health challenges and their needs more openly now than ever before. I'm also hopeful about the fact that more and more kids are able to find their people a little bit more easily compared to back in the day. And so even though everyone's afraid of social media and what have you, it's a very powerful tool because it allows for kids, especially in certain communities where there aren't people who look like them, who have similar experiences, they're able to connect to other people across the country who do, so they don't feel alone, and that can help with anxiety, can help with depression. So I just appreciate how communicative folks are about their experiences. I also love the fact that kids are asking about mental health days and just saying, I'm feeling overwhelmed. I just need to take a day to reset, and knowing how to do so in an appropriate way rather than in a way to get out of an exam or something like that. And I'm also hopeful about the fact that more parents seem to be a little bit more willing to bring their kids in for help and to see me, and to not see kind of the referral to me as a failure on their part as a parent. So it's good that I'm seeing less of that, which is reassuring, but still part of a lot of folks' experiences. What worries me the most is loneliness. I think kids are profoundly lonely nowadays. And I didn't really think a lot about loneliness until I was asked to do some work with Girl Scouts. And Girl Scouts of America, they conducted a study with girls between the ages of 6 to 13. And the whole point of the study was really to encourage more families to get their kids connected to pro-social activities like Girl Scouts and kind of how helpful it was. But they were astonished by the high rates of loneliness, kind of reports of loneliness that were found on that survey. It was through the roof, 6 years old to 13. And even though a lot of young people are surrounded by lots of people, whether that be at school, whether that be, their peer groups, whether that be even at home, because there's siblings, there's parents, people aren't connecting and engaging in the way they used to before. They're not engaging in a way in which they are fully present. It seems like people are more distracted now than ever before. So even when everyone's sitting down to have dinner, if you're able to do that, which is huge, but when you do that, like, there are phones there, and like right now, I just picked up my phone and I see a text and you're like distracted right now, and so your mind is always like 10 or 20% somewhere else. And when that happens, especially as a parent or other adults, what could happen is you start to not really notice subtle changes in your kids, right? You may not notice certain changes in their behavior because you're 10% or 20% somewhere else. And when you don't notice certain things, then you're not curious about some of these changes. And so I'm seeing these conversations not happening as often. I do see parents making attempts. How you doing? Mom, get out of my face. This is dumb. Okay, and then mom's done. Or maybe mom tries like 8 times, and they're like, you know what, Bob doesn't want anything to do with me. Whatever. But I tell parents, you have to be persistent. Even if it's like 6 months, 1 year, and they're like, you're being weird asking me all these questions. Who knows, a year from now, they finally could come to you and be like, Mom, yeah, I really want to talk to you about X, Y, and Z. So I'm seeing that parents being distracted is a thing. The type of interactions and connections aren't as robust as they used to be. And kids are able to retreat in their phones, away in their phones or in their gaming systems. Even though they're still connected with others, it's not in a deep and meaningful of a way as it ought to be. And so it's easy to be superficial with people when you're online, when you're gaming, everything is superficial, but it's harder to hide when you are being confronted with someone right in your face. Who's saying, I'm noticing these things in you, help me understand them. So yeah, loneliness is a huge thing. And also with adults, because the number of families that I meet in which the parents don't have friends themselves, they tend to prioritize their kids, which is great, but kids aren't being exposed to other adults coming into the home or extended family or other friends. A lot of these homes, they just feel so like siloed. Before, when people were kind of more into like the neighborhood vibe and being like a community, we're seeing people kind of isolate themselves more and more as a family. I'm not saying that's the case for you guys, but it's just something that I've noticed more broadly.
Thank you so much, Dr. Crawford. We appreciate you being here and appreciate all this fabulous information. So let's thank Dr. Christine Crawford.
And thanks for all the questions too. Thank you.
And if you would like a book, again, they are just $20, so we'd be happy to take cash, or we'll also set up for credit cards, and Dr. Crawford will sign them